Afternoon, good evening, good morning if we have any Australians on. Hello everyone. Welcome, welcome. Today is Friday, June 19th. My name is Andrea Merriam. I'm with the PMD Alliance. I'm so excited that you are joining us here. We've been looking forward to this talk forever, it seems like. And I'll go ahead and turn it over to our neurologist host, Dr. Subramanian, to tell us a little bit about the speaker and what we have in store for today. So go for it, Indu.
Okay, thank you. Welcome everyone, virtual wave and hugs from here in Santa Monica. I know many people are joining from all over the place, and we're happy to connect virtually here as we're physically distanced, but we're socially connecting on here. So it's Friday again, and we look forward to hopefully a beautiful weekend for everyone. I'm so pleased to introduce Wayne Jonas to all of you. We've had a number of speakers just in the traditional Parkinson's world, some of our allied healthcare providers and folks. But I wanted to bring you a speaker that has really inspired me. I've been going to meetings, not just in the movement disorders world, but also in the integrative medicine world, and was inspired to end up taking my boards last year and becoming part of this community, which I've been really excited to be part of and bring some of the wealth of that teaching to you. So today we have Wayne Jonas, who's a tremendously sought after speaker. You will have links to his website, and you will be impressed, as I have been, with all the different things that he's done in his career to date. He's a family doctor, family physician, but he was the former director at the NIH Office of Alternative Medicine, the former director of the World Health Organization Center for Traditional Medicine, the former director of the Medical Research Fellowship at the Walter Reed Army Institute of Research. He's also a retired Lieutenant Colonel for the United States Army Medical Corps. He's just done a tremendous amount, and currently he's working with the Samueli Integrative Health programs, and he can tell us a little bit more about his current ventures, but I think you can see that he's had such a wealth of history of practicing medicine and seeing it evolve over the years. And I really hope to give you guys a taste of what his view of health and sort of his view on how to improve our health through a number of different approaches that I think many people are starting to adopt, including at the VA where I work. So without further ado, I'm gonna hand it over to Dr. Jonas. He's gonna present us some slides about his approach, and then we'll turn it around to some questions and answers to make it a little bit more Parkinson specific. But welcome everyone, and thank you, Dr. Jonas.
Thank you, Dr. Subramanian, and it's a great pleasure to be here to address your group and in this very, very important condition or conditions that affect people and how we can facilitate and improve health in those situations, even if a cure isn't always necessarily available in those areas. So what I'd like to do is make some comments for, about 30, 40 minutes or so, and sort of lay out to you a new model of care that I think is needed. And in this age of COVID, and hopefully soon post-COVID, are going to be even more important. And I'll show you why, actually, in these areas. So I call this How Healing Works. What it is about is something called integrative health. And I'll define that for you. I'll tell you what that means and what it looks like, and why it is really the new model we need to move forward in both the management of chronic illnesses and in a post-COVID world. So can you see that slide there?
Yeah,
okay,
perfect.
Is that displaying? Great. So I live in Washington, and every few years, Washington has a big debate on healthcare reform. And it's going to be a real big one this time in the environment that we're in right now. And the debate is always about, gee, who's going to pay for healthcare? How are we going to provide it to people? Should it be the employer? Should it be the government? Should it be the people themselves in those areas? And I submit to you that that is the completely wrong question to be asking. And if we only ask that question, we're going to continue to have challenges that even answering that question will not be able to address. The question we need to be asking is, how do we get from healthcare to actual health and well-being? And if we're not producing health and well-being with healthcare, then what are we paying for in those areas? What I mean by that with an actual patient. Now, this wasn't a Parkinson's patient, but it's somebody who did end up with movement problems. Her name was Sally. She was an executive that worked for the Pentagon, and I spent a large part of my career taking care of military eligible people like Sally, who had what I call platinum level health care. Sally had available any kind of specialist, primary care, medical intervention, medication, totally free of charge. She ran a huge program at the Pentagon, very, very busy, constantly on the road, constantly in meetings, etc. She was on her way to the Pentagon one day, and she rear-ended another car. She had a car accident. Her car was totaled. They called the ambulance. They brought her and did to the emergency room and did tests. She was having some back and neck pain at the time, but nothing was broken, and they gave her non-steroidal anti-inflammatory drugs and told her to go to physical therapy, which she did once, began to feel a little bit better, but then got back on her busy schedule and started continuing her life. Then a few months later, still with some back pain, she tried to lift up her suitcase to go get on a plane. I guess we don't have that problem now anymore, but she had a pop, and she had excruciating pain down her leg. She couldn't stand up. She says, "Oh my God, I've really done it now." She called 911. They brought her back to the emergency room. And because she had already had physical therapy and non-steroidal, something that happens a lot, which is an opioid. And she took the first dose of the opioid and she said, "This is really good stuff. I like this. This helps my pain." And she began to take more of it. And she developed something that is unfortunately very common, opioid tolerance syndrome, in which she had to continue to up the amount of opioid that she was on in order to get the same amount of pain. And eventually she started to have problems with that. Because she had platinum level health care, she got everything: x-rays, CT, MRI, non-steroidals, 10 units, injections, opioids, etc. Eventually she was sent to behavioral medicine, where she got another diagnosis, depression, and she was put on another medication. She was told to get off her opioids and go into opioid recovery. She said, "I'm not an addict, I'm in pain." She refused to do it, but she also then had to quit her job because she had too much disability. This lasted for 10 years. This is what people so often get when they get a chronic illness like Sally's with platinum level health insurance. Now, the reason that she got all of these treatments is because of a little tool that healthcare providers know, physicians know, because they use it thousands of times a day around the country and the world. It's called the SOAP note. Its goal is to make a medical diagnosis and a treatment plan by asking the patient, "What's the matter?" That's the chief complaint. That's followed by subjective, what the patient describes, objective assessments, that's the O, assessment, the diagnosis, and the plan, which, if it is associated with the diagnosis with good evidence, then can be paid for. The SOAP note is done by multiple people, and she Sally had this over many, many years, many SOAP notes. And this was Sally's team. I use the term team in quotes because they weren't individual care providers, family physician, physical therapist, surgeon, behavioral medicine, etc. All of them giving her more pills and procedures of various types, or in the case of physical therapists, exercises, etc. But they weren't coordinating. Sally had to coordinate this. And this did not result in an improvement or alleviation of her pain. Now, in the military, we don't get paid, surgeons don't get paid for doing procedures. So when she went to the surgeon said, you actually don't have a surgical procedure, which is 85% of people with conditions like Sally with chronic back pain. So she ended up not with surgery, but if she'd been on the outside, very likely would have gotten surgery and gotten it paid for. Unfortunately, Sally's situation is all too common. All of you, I'm sure, have heard about the opioid epidemic. It has not stopped because of the COVID pandemic. It's still going on. It's getting worse, in fact. But prior to COVID, there was a huge problem with opioid-related deaths, with inappropriate opioid prescriptions and use by Americans. And there were two presidential commissions, and every state in the union was trying to address this in some way. Now, those who looked at the evidence said, okay, we have to use less medications, especially opioids, and we need to use more non-pharmacological approaches. These were drugless approaches. The American College of Physicians, the FDA, Food and Drug Administration, et cetera, all said uses. The DOD and the VA began to implement these areas. Had we been listening to our patients for the last 30 years, we would have realized that those in chronic pain were already doing this. They just had a different term for it. It was called complementary and alternative medicine, or now integrative medicine. And it involved things like therapeutic massage, yoga, acupuncture, spinal manipulation, and mind-body therapies, many of which actually now have evidence for improvement in conditions like Sally's. However, we had a problem, Houston. The problem was that I didn't know how to deliver these therapies. I wasn't taught in medical school how to do it. The patients weren't asking for them. They were going outside the system, so it wasn't getting integrated into my treatment plan. And these weren't paid for. Even Sally, with platinum level health insurance, couldn't get many of these kinds of therapies. We had a cultural problem. This was not a single process that could be solved. Well, how do you solve a cultural problem? The very first thing that has to happen to begin to change the culture is you have to change the way we think about how healing works. We have an outdated model for chronic disease. It works very good when you have an acute disease, a car accident, heart attack, a tumor that needs to be removed, or a broken bone. You can treat your body like a machine, okay? Like a car, in which a molecule is placed in it or a new part is replaced, and you can get some benefit from that. But for the vast majority of chronic illnesses, this does not. The chronic illness management has to take a much more holistic approach, because chronic diseases involve all levels of what a person actually is. Not only their body and the external environment, but their behavior and lifestyle, their social and emotional environment, which everybody has one of those. And we're acutely seeing this now with social distancing, and the spiritual and the mental component. Unless we address all of these, we cannot appropriately address chronic disease in the whole person. So how do you do this? This is how I do it in my practices, and a number of groups around the country are adopting this more and more. I call it going from soap to hope. HOPE stands for Healing-Oriented Practices and Environments, and it is a set of questions and dialogues that the provider and the patient have, that instead of asking what's the matter, it asks what matters to the patient, what's important for them. That's really a mental and a spiritual question. And then it explores the underlying personal determinants of a person's health: the social and emotional, the behavioral and lifestyle, and the body and external components. And it puts these together in a way to then tap into those inherent healing capacities that everybody has. So here's how it worked with Sally. When I asked Sally what mattered to her, the first thing, as so many patients will say, is that I need help with my medication management. I'm taking all these different medications that people are prescribing, and how do I manage that? And I said, Sally, you're in luck. We have on our team a pharmacologist, and I'm trained at medical management. I can help you with that. But I want to know, Sally, how you address your own pain and function separate from pills and procedures. And she said, oh, that's easy. I figured that out a long time ago. I found that heat and stretching really help my back. So I bought a hot tub. And in the morning, every morning, I get up, I get my cup of coffee, I get in the hot tub, and I stretch and stretch and stretch for an hour. And if I do that, I can start to make it maybe through noon, sometimes if I'm lucky till the afternoon when the kids start coming home and I need to start working on helping take care of them. I said, Sally, this sounds like yoga to me. Have you ever done that? She said, oh yeah, I went to one of those classes and the woman was up in a pretzel all bound up like that and I hurt myself. Yoga doesn't work for me. What Sally had tried was not evidence-based yoga that is recommended by the American College of Physicians. It was an attempt to provide non-evidence-based yoga for back pain. But yoga was something she was trying to do. And I said, Sally, would you be interested in doing good evidence-based yoga for back pain? She said, yes, I would love. It seems to be what I'm doing. How's your sleep, Sally? Oh, it's terrible. I've never really slept much. My mind always goes, and now the pain makes it worse. And I'm not really rested in the morning. Probably the reason that she got in a car accident in the first place. What she didn't realize, however, is that poor sleep aggravates inflammation in the body and perpetuates chronic pain. I asked Sally how her stress was, and she says, I don't have any stress. I used to have a lot of stress when I was having meetings every 5 minutes in my calendar, and I was running around in my bigwig job. But now I just sit at home, sit in the hot tub, manage my pain. Sally did not realize that chronic pain induces stress, bumps up cortisol, aggravates chronic pain and inflammation, and perpetuates the situation she had. That she actually had stress, but she had normalized it and didn't think that she had to do anything like that. Her stress management consisted of getting a drink in the evening and turning on the TV. When I asked Sally if we did get her set up with evidence-based yoga, non-drug approaches, where would she do it? She couldn't think of it. I said, what about the bedroom? Well, it's kind of a mess. The wall needs to be repaired. People are coming in and out. Every time I'm in there, I feel like I've got stuff to do. It was not a relaxing place for her. But the most important thing that we got to around what mattered for Sally was the fact that her disease had undermined her purpose. She said, Doc, I knew that I was doomed. And that's the word she used, doomed, when my family started calling me Sally again. And I said, isn't that your name? She said, yeah, but they used to call me Salary because I brought home the bacon. I was the worker. I had a great job and I loved it. And now my back has stopped this, and she had lost her purpose in life. And right now she blamed it on her back. So now with this interview, this dialogue in mind, we knew exactly what to do with Sally. It sounds hopeless, but it actually gave us hope. We now knew what kind of team she needed, but we needed them actually working as a team. I was the coordinator at the top. We needed the pharmacologist on board to help with her medication management. We needed the behaviorist, but not doing counseling and giving her a diagnosis. We needed the behaviorist to act like a health coach to support her in her healing journey. We had all those on our team. Platinum Level Healthcare actually has most of these types of folks. What we didn't have was a yoga therapist. She was going to have to figure out how to pay for that, and we were going to have to get her connected with one of a person that could do this specifically for back pain, and they had to be coordinated working with the team. We needed her family on board so that she could begin to engage in this and they would support her in her own healing journey. And we needed her body on board. And what I mean is we needed her mind view, her mindset about her body. We needed her to see her body differently and to understand that it actually could heal. Once we got this coordinated, I sent her over to the yoga therapist. She got therapeutic yoga for her back pain, and she called me up after her first visit and said, hey, my pain is down to 2. It hasn't been down to 2 in 5 years unless I'm sitting in the tub. She then got the message that she could be involved in that. Now, she wasn't cured by any means, but she was on her way with the support of her team to be able to engage in her healing journey. And after about 3 months of regular therapeutic yoga, most of which she could do at home, her pain levels were regularly down to 2. And after about 6 months, she came in and said, I think I'm going to go out and look for a job. She began to restore her purpose in life, which was what was motivating her in the beginning. This is a different kind of healthcare, but it's the kind we need. It is the merger of conventional medicine, the kind I was trained in and delivers, with evidence-based complementary and alternative medicine like the yoga, and self-care to support her in the integration of that, of her own behavioral changes. It all has to be done within the cultural context, because if she hadn't had the family and the resources and the ability to do that, we would have had to address that in some way, the so-called social determinants of health. If we don't move to this type of healthcare, this merger in the middle, if we just stay in that top circle where most of us are, and if healthcare debate in policy says just get more of that, we're going to continue to get more of what we have. And here is what we have. We are first in spending. We are 37th in healthcare around the world, according to the WHO. By 2025, we may end up spending 25% of our gross national product on healthcare, which is totally unsustainable. And because of the rising cost, health disparities, the differences between the haves and the have-nots and the access is widening. And that gap was growing even before COVID and is now growing faster. There's many reports out on this. The data is clear. Here's a report from the National Academy of Sciences, the former Institute of Medicine, called Shorter Lives, Poorer Health. And when compared to other rich countries in the world, we are falling behind over the last 30 years in multiple chronic disease situations. And here's a list of some of them. Here's a slide that illustrates the declining value of healthcare as we currently deliver it. This is mapping the per capita cost, the cost per patient, with life expectancy around the world. And as you can see, the US on cost is a major outlier. We have double the costs of any other country in the world, but our life expectancy is somewhere around Czechoslovakia or Portugal. Why is this happening? It's happening because medical treatment, healthcare, only produces about 15 to 20% of our actual health in the population. And again, this has been shown over and over again. There's even databases that track this. The reason is because health comes primarily from 2 other places: behavior and lifestyle, and the social and economic determinants of disease. So if healthcare is going to be part of the solution, rather than the expensive problem, we're going to have to get out of the top little black area and begin to help facilitate addressing the actual determinants of health that we see on this slide. This has not changed in the era of COVID. If you look at the rates of COVID per population, and per million and per 2,000, and the number of people that need some kind of health intervention, it's not any different than this. There aren't any treatments. We don't have any vaccines. Those who get really sick need some kind of supportive care, but it doesn't go over 15 or 20%. The vast majority of prevention is self-care and behavior, and increasingly the social and economic impacts that we see. If you ask who dies with COVID, it's the same people who were dying before COVID: the elderly, those with chronic illnesses, Blacks, Hispanics, those with low income, poor health care, and poor health. The same things, but COVID has now shown a rapid spotlight on what was going on with chronic diseases all along. We do need to protect ourselves from the spread, and the CDC has provided excellent guidelines on that. I urge you all to pay close attention to those and try to prevent the spread of this deadly virus. But in addition to stopping the virus, we need to do those things that will enhance our health that are listed at the bottom here, the same things that prevent chronic disease and chronic risk factors, underlying determinants, are the same things that can help boost your resilience and your immune system and prevent you from getting sick from this. I have a set of resources, and we'll provide these slides to you after, that we have built just for the COVID age to help avoid burnout as this goes on, for boosting the immune system, and for building resilience as social isolation is taking an increasing toll on our mental health in those areas. And I urge you to look at those and implement them. So pre-COVID, during COVID, post-COVID, health and well-being comes from empowering and supporting healthcare in an integrated fashion where evidence-based, conventional, complementary, and lifestyle are put together in a single delivery system. And the evidence shows if the patient is part of that team, they will be healthier and they will lower costs in those areas. Now, I'm often asked, can we do this within our current system that mainly stays up in that one little circle of pills and procedure? And the answer is yes, we can do this. And here's some examples. The military that Sally worked in, I see patients in that platinum level. It is integrating these kinds of behavior non-pharmacological approaches. Here's the students at the military medical school, all getting trained in something called battlefield acupuncture. It's a simple ear technique. They've now trained 6,000 providers. Every single medical and nursing student comes out trained in it, and it's available anywhere in the DoD healthcare system. They have also begun to implement the performance triad, which is sleep, nutrition, and exercise, and they all come out with skills. That was the last Surgeon General's signature component. The Veterans Administration has one-upped them on this. They have actually implemented something called Whole Health and have 18 centers of excellence delivering integrative health around their system for all whole persons and all vets. The patient sets the goals. Using a little tool I'll show you that I've adapted from them to use outside the Veterans Administration called the Personal Health Inventory, and then the health team supports them in getting there. Here's their model. I love it. It's an empowerment model. First, you explore what matters to the person, like I did with Sally, equip them with self-care and integrative health skills, and then integrate that with the treatment team through something called the Personal Health Plan. And I'll show you how that's done in just a minute. And how we do it outside the Veterans Administration. The Veterans Administration has just come out with a report looking at not only health improvement, but cost savings on 133,000 veterans who engaged in this program, and over a period of a year saved $650 million off of the healthcare system by engaging that. Outside, I am asked frequently, okay, that's great if you're paid for already, like the DoD and the VA, but how are we going to pay for it? My answer is, if you're not doing this, you're already paying for it, and you're already paying way too much. 5% of the patients that come into the healthcare system account for 50% of all medical costs. Unbelievable. These are called advanced illness. They're the top of the pyramid of the most sick of the sick. They got there by going up the pyramid. They were at risk for multiple chronic diseases that were not reversed or prevented, or at one point they were healthy. We're trying to save costs, logically, in that top 5%, but we're not doing anything to help them move down the pyramid or prevent those who are going up the pyramid for that other 95%. We need to address the costs in that advanced care, and we have a term for that: integrative, coordinated hospital care, integrating primary care, reducing specialist visits, hospital visits, ED visits, but we need an integrative health program that addresses the other 95%, through health promotion, lifestyle health coaches, and reducing other unnecessary types of treatments. There's a term for this, and you'll hear it come back again during the healthcare debate as we go into the elections. It's called value-based care. And what it means is paying for value, good outcomes, not volume, pills and procedures. And what we have in our system is that we have a toe in the value-based care boat, but we're still standing on the volume-based dock. And we need to get in the boat because the boat is leaving the dock and we are going to fall in the lake if we don't actually get in the boat with total value-based care. So what can providers do and what can patients do to try to make this happen? I have a set of tools. The first thing they do is make sure they're doing good medical care. You got to have the SOAP note. I needed to know what Sally's diagnosis was before I could begin to address her underlying determinants. So continue that. But then do an integrative health visit using the kinds of tools, the personal health inventory, PHI, and the HOPE note that I just described with Sally. Reframe the questions and the dialogue that goes in to the health encounter. Add some simple methods, non-drug approaches like ear acupuncture, mind-body approaches, appropriate nutrition, and safe supplements. Bring in advanced healing technologies. Heart rate variability, various devices, behavioral apps are allowing us to do this quickly, and now telehealth has become the dominant way for delivering health. Learn how to do that and learn how to do it better. Redesign your healthcare team so it's not just a top-down, the physician has to write all the orders. The health teams that engage health coaches, team care, group visits, and the patient through shared decision-making are able to do this in a much more effective and less costly way. What are the patient's responsibilities? Self-care is where they need to focus, and they need to realize that that's where primarily where health comes from. They only get about 20% from coming in to see the doctor. They need to engage the other 80%. Find your meaning. The personal health inventory asks you what matters, and it helps you identify your own underlying personal determinants and start on your healing journey. Ask a provider to do an integrative health visit, and if they don't know how to do it, I'll show you. They can go to my website, and there's instructions and a toolkit exactly how to do it there, and it's all free. Develop their own healthcare team. You have to have a team to take care of chronic illness or even acute illness, as we've seen, that involves traditional, complementary health coaches, conventional care, and they need to work, as I've illustrated with Sally, as a team. In order to get better. What about people with movement disorders and Parkinson's disease? Well, there's a growing amount of evidence that many of the integrative health kinds of approaches can be very beneficial for those with movement disorders and Parkinson's disease. The diet, for example, the Mediterranean diet, which helps multiple illnesses and helps people stay healthy, has been tested in Parkinson's disease and demonstrated to have multiple health benefits in Parkinson's patients. Exercise of various types can also help Parkinson's patients and those with movement disorders. Tai Chi, for example, helps with balance and reducing falls. Aerobic exercise and other types can improve not only physical but cognitive function. Acupuncture has been looked at in randomized studies with Parkinson's patients and shown to reduce symptoms and improve function. Mixed integrative programs have impacted hospitalizations, for example, and therefore reduce costs and the traumas that occur from that. The Mayo Clinic has an excellent guide on integrative health specifically for Parkinson's patients. There's the link. Again, I'll send you the slides. They have a great number of tools. So there's no excuse for not doing it in those with movement disorders now, as we have evidence growing in those areas. If you'd like to know how to do this, or if your provider would like to know how to do this, my foundation, I'm funded specifically to help provide tools to assist in getting these kinds of things easily out. It shows how you prepare for an integrative health visit, how you do that with a HOPE note in the PHI, and then how you provide continuing resources and support that are available in those areas. Here's the personal health inventory. It asks patients why do they want to be healthy and identifies what matters and what their personal determinants of health are. It helps you start with that and begin the dialogue. Here's the questions that go into the Hope Note. I do this every day within my regular internal medicine and family medicine practice. And here's some of the questions. These are the questions I asked Sally that got her to understand and begin on her healing journey. They start with the body and behavior components, behavior and lifestyle, social and emotional, which everybody needs, and the spiritual and mental components, identifying and aligning healthcare with what matters in life. Why do you want healthcare? Out of that comes a personal health plan, which then allows the team and you to move forward in those areas. If you're going to wait for Washington to set up and change healthcare policy to allow you to improve your health, you're going to wait a long time. And that's true no matter who wins the next election in those areas. But you can start now. You can actually begin this process. You can begin to do integrative and whole person health by engaging in what produces health for patients and for practitioners in those areas. So thank you very much for your time and attention. I will stop right there, and I look forward to any kind of dialogue and discussions that you have.
Thank you so much. That was really a great introduction to kind of a different look at health and how we can approach this. And you have this wealth of information, being a family practitioner for so long, and then looking at the deficiencies that you've sort of noticed over the last decades of practicing and trying to define, a hope for the future, which I really appreciate. And I think, as Parkinson's advocates and doctors and patients and caregivers on this call, I think we can all sort of see, hopefully with the current state of medicine, with all of these healthcare disparities that we're sort of highlighting, and these sort of sense that there's really something that has to be done to change many things of society moving forward. I think we can kind of look at this as a resetting point and seeing what the hopes are for the future. So I think that that's really something that we kind of need to sort of think about. One thing that I wanted to ask you about, Dr. Jonas, because in a disease like Parkinson's, the mind and the body are very connected. And you talk about, sort of this concept of, rather than pathogenesis, this concept of salutogenesis, which is quite interesting, and what kind of appealed to me when I was reading about, this area of medicine and what made me sort of want to delve more into it. Could you kind of clarify those terms and maybe talk about that from your beliefs and your background, and how it might appeal to or be relevant in a Parkinson's disease patient?
Sure, I'd happy to, and thank you for introducing those. Those are technical terms that I tend not to use in mixed audiences, but I learned from the textbook of pathology, as I'm sure Dr. Subramanian, you probably did too, and that is how disease happens, okay? We know a lot about how disease happens, and medicine is set up around to try to stop that process. Well, the flip side of that, and that's called pathogenesis, the genesis of disease. But the flip side of that our bodies are engaged in all the time to prevent and to help us heal and recover, is the genesis of health. And that is saluto is health, and genesis, okay? So salutogenesis is the process of healing. And medicine, for the most part, does really good at stopping disease, okay? It is not very good at facilitating healing. And when you have a chronic condition, you need both, okay? You need to integrate them and put them together. And that salutogenesis involves working with the body to tap into its own inherent healing capacities and facilitate that process. Very often, it can help with those clinical conditions. Sometimes it can reverse them. Diabetes, obesity, for example, hypertension can all be reversed. Parkinson's can't necessarily be reversed with those types of things, but the progression of the disease can be slowed, the function can be improved, the health and well-being of the person can be improved in those areas. And so we need the health component, salutogenesis, and the disease component integrated together.
That sounds, thank you for clarifying that. I wanted to ask you about your sense of, you write a lot about the placebo response, and in a disease like Parkinson's, so many of our trials and studies have actually been hard to do because there's a huge placebo response in many of our patients around pills that they might take, or even when they come to an integrative practitioner. A lot of the times, for example, one of the acupuncture studies that's out there was actually beneficial in both the sham sites as well as where the real acupuncture points were in some of the studies that we've done. So maybe you could talk about the placebo response, and you actually have talked about harnessing that placebo response to get benefit in certain disease states. And maybe you could talk a little bit about that.
Yes, I actually think the term placebo response is a misnomer. Yeah, we shouldn't be calling it the placebo response. It should really be called, and I write about this in my book. In fact, I give examples of Parkinson's patients. I've used it in the book. It should be called the meaning and context response, okay? Because it's about the rituals of care. And the rituals of care, we now know from research in which placebos, inert substance, have been used and people have gotten better. We've realized that the rituals of care and the beliefs around care all are very powerful, including in Parkinson's disease. And so enhancing and tapping into those responses is really what we should be doing. Instead of throwing them out if we can't show that, you know, the pill works more. In fact, it doesn't matter if it's conventional medicine, self-care, or complementary medicine. We know that a huge amount of recovery has to do with the rituals of care, has to do with our beliefs and expectations, has to do with our engagement in those areas. And so even if we have a proven therapy where the drug works a little bit more than the ritual of care, and this is why it's so expensive, rituals of care in which inert substances are used actually still often get people better. It doesn't mean we should throw the baby out with the bathwater if we can't show it's better than placebo. We want to use things that actually work. So, you know, let's not use everything. Let's find things that's worth, but then let's bring the rituals and the beliefs and enhancements back into the delivery of those things and show them. Sham acupuncture does work when it comes to pain. Real acupuncture works better. That's been proven, published in mainstream journals, etc. But it's the same way with other kind of painkillers. They do work, but the ritual of delivering them also enhances their effect. So let's make sure we put those things together the entire time.
So you talk about social connection as something that's important in your books. And also, I think, you know, that's become something highlighted in the setting of COVID-19. Can you talk about that just from, you know, the aging populations and many of the populations that you're studying? And I think you also did a recent survey that was published, or that I saw, you know, about some of the folks that are, you know, you've surveyed in the COVID timeframe. And maybe you could speak a little bit about what your survey also found.
Yeah, we just commissioned the Harris Poll to do a survey specifically looking at how people are dealing with COVID around behavior and self-care and around social and emotional and mental health issues. And what it showed, probably the most important finding it found, is that the importance of self-care has been markedly increased. People have realized and have said that, I know even after COVID, I'm going to pay a lot more attention to self-care because I know it's important for building my resilience and enhancing my mental health. I don't know of any person who doesn't have a social and emotional body that isn't somehow a social and emotional animal. They don't have to have a mental disease to know that social and emotional connection is important for taking care of themselves. And so I always bring in questions about social support. If those are missing in a patient's life, I ask them, are there ways to enhance that? Are there ways we can help bring that in? in those areas. And the other thing the survey showed is that they need help with it. Mental health is getting worse as this social distancing goes on. And now there's a lot of connections around the world we can make on Zoom like we're doing right now, but you know, they're not making up for it. They're not making up for the personal connections that we as humans need. And so we need assistance in that. That's not going to go away after COVID and when those things return. And so the social and emotional components are key. Loneliness, for example, was epidemic and has been exacerbated by COVID. It's been shown that loneliness is as increases your risk for heart disease, for example, to the same level as smoking a half a pack of cigarettes a day. Okay, we'll ask you about your cigarette smoking. Rarely do we ask about loneliness. We need to start doing it and beginning to address the social and emotional components.
Yeah, and even I think it's as bad for you as obesity. I mean, it's a real epidemic even before the pandemic that's happened, I think, and we have data on that as well in the Parkinson's population. And in our surveys, we found that loneliness is as bad for you as if you exercise 6 days a week. 30 minutes a day is good for you. So it's really, you know, a very important thing that is gone probably unnoticed and under-recognized for a long time. So I think there's a lot of sense, just looking at the chat, that people want sort of practical, you know, low-hanging fruit, sort of where to start in the self-care. You know, if people are at home now, we don't have, you know, Medicare is not paying for certain things, you know, in the list of things that might be good for us. We may not have access to some of these things living remotely. You know, some of our patients on the line may be living, you know, in their homes, sort of stuck, worried about going outside. Could you tell us, Dr. Jonas, from your perspective, and you did list some things about some supplements, and we can get into those. What are your maybe top 5 tips for people who are living maybe with chronic disease and their caregivers, who are also very important? And I know you've done a lot of work in caregiver support and research in that. Maybe you could tell us the top 5 tips maybe for people who could practically apply them at home today.
Be happy to do that. And actually, if you go on my website, we have a lot of resources for engaging in non-drug approaches, integrative approaches. We synthesize the evidence and talk about how to find qualified practitioners if they're needed, as well as bringing in guides to self-care and how to put those together. So top 5, okay? Number 1, I think, is mind-body practices, okay? What is that? Okay, our brain is not separate from our body. I just did an hour-and-a-half workshop with a bunch of providers up in Queens, New York, who were at the heart of the COVID bomb. They were hit by COVID at its peak and epidemic, 1,000 people a day, 100 people dying a day for a number of years, and they are stunned. And what we did is we went through a number of ways to help them build mental resilience. And one of the ways you do that is through mind-body practices. And there's a variety of them. There's a whole list of things to do. Engaging in some type of mind-body practice builds your mental muscle. It actually helps protect you from the stresses and the strains that inevitably we're faced from. And this has been shown, for example, to engage in 8 weeks of 20 minutes of deep relaxation response or meditation or mindfulness a day will actually grow your frontal lobe. You can see it on MRI. At 10 minutes of some type of relaxation response will mitigate half of the stress genes that are turned on when you're engaged in stress. So that would be number 1. Number 2 is food. Now, there has been no specific food or pill or supplement that has been shown to cure movement disorders or Parkinson's disease. But the Mediterranean diet, which is a high plant-based diet of whole foods, high in omega-3s, high in vitamin D, high in zinc, that has been shown, high in fruits and vegetables, high in nuts. That has been shown over and over again to reduce risk for chronic illnesses, including improve function and health and well-being, both mentally and physically, in those with movement disorders and Parkinson's. So number 2 would be shifting your diet. I have a guide on my website called the anti-inflammatory diet. We now know that inflammation underlies a lot of chronic illnesses. And there are a set of simple foods that reduce inflammation and others that will aggravate it. And what I recommend to patients is they just begin to move over to the anti-inflammatory side and incorporate that into their routine diet. I think the third one is social connection. And it would be a debate now in the age of COVID whether that should go to the top, right, in social connection. And that is, if you are lonely, if you don't have a good social support network, then look for doing that. It's not about the number of Facebook friends you have. It's not about quantity. It's about quality. Is it somebody that you feel relaxed with, that you're comfortable with, that you can rely on, that you can trust? And all you need is a few of those folks. Cultivate that component, somebody that you can rely on. If you are a caregiver and you're providing that caregiving, okay, that aren't related to the caregiving, so look for that. The fourth thing I would say was movement. Over and over again, movement has been shown to be salutogenic, to use your term. It taps into our own inherent healing capacity. It is an underlying fundamental way to keep us going. And it doesn't have to be going to the gym and working out, you know, until you drop. In fact, that might not be good for people with chronic illnesses. It's a matter of engaging in activities of daily living on a routine and a regular basis. Study just came out 2 days ago, again, confirming with over 8,000 people that there's a dose response in terms of moving it, engaging in the things that you enjoy, that you love in those areas. Do you need a fifth one?
How about sleep? Do you want to speak about sleep?
I'd say the fifth one is making, yeah, I'd say, I was about to say that, actually, very good. I would say the fifth one is sleep. Sleep has been shown over and over again to be salutogenic, again, to use that word. And this is across the board. It is restorative. It helps people recovery. It helps healing. Lack of sleep will impair the immune system a single time, okay? And in fact, with many of my patients, they'll come in for all kinds of chronic illnesses, okay? And if their sleep is disrupted, if I can get that improved, many of their chronic illnesses will actually improve just by that one intervention. And you saw that with Sally. Sally, I didn't talk about it, but sleep was a huge issue for her, and we had to support her in that area. So you got the big five right there.
Okay, that sounds good. Maybe just an end, because I think sleep has become so important in the COVID-19 sort of timeframe. A lot of people have disrupted their home schedules so much and end up sort of switching and their day and night, and you know, it's just sort of becomes very hard, since normal daytime would be punctuated by going out and doing different activities. Could you maybe give us maybe a couple of things in terms of your pearls of where to start with somebody who's very frustrated with their sleep patterns? Because I think that's been in the chat a little bit.
Yeah. So I had a patient actually just 2 days ago who we had this very discussion. Number one is good sleep hygiene, and this has been shown to be very effective. This patient came in and she had to have the TV on in order to go to sleep, okay? And we talked about that, and she said, well, I need the noise, etc. Well, what she didn't realize is that the light coming out of the TV was suppressing her melatonin and was interfering with her sleep all through the night. And so we worked with her to try to get some white noise and get the TV off. And when she stopped that, she found it improved. There's something called sleep hygiene, and behaviorists will go through that. There's a set of behaviors. And in fact, there is something called cognitive behavior for insomnia. And there is an app, CBTI, which actually can take you through sleep and sleep hygiene in those areas. So that, I think, is most important. Number two is to try to work to get off sleep medications. Over and over, it's been shown that sleep medications like opioids are great for a temporary thing. You can use them for, for short-term component, but in the long run, they actually will disrupt sleep, okay? So looking to go off of those types of things. People will use non-medication things like alcohol, for example, to try to reduce the so-called nightcap. That also disrupts the quality of your sleep. And so that is a type of non-prescribed medication. Mind-body approaches are very good for inducing sleep. I use something with people called the Alpha Stem. It's not been FDA approved, but it's been FDA cleared. It's a little device that helps induce an alpha wave, which is sort of like a relaxation response. And I pair that with training people in their own mind-body technique to help that, and it's been shown to improve sleep. Sometimes I will temporarily use supplements, but you got to know how to use them. You got to make sure you don't have chronic illnesses. I had a woman yesterday, actually, who was taking high doses of an herb, valerian and kava kava, et cetera, which can be helpful sometimes, but she had liver disease, and that can impact the liver. So we had to get her off of that in those areas. So sometimes that can be temporary also and can assist in those areas, to help get to more detailed sleep. Being dark is part of standard hygiene, and you'll find that, again, on my website. I provide a sleep guide and a direction for sleep on that.
That's great. Thank you. So it sounds like you're quite interested in these apps, and I think you may have some directions about some apps that you like on your website as well. So that's good to sort of learn about new technology and try to incorporate it. So maybe in the last few minutes, Dr. Jonas, I just wanted to give our audience a sense of, we have Parkinson's patients largely and their caregivers who are hungry to learn about how to shift the current healthcare system to incorporate some of these sorts of things that we're talking about. From an advocacy perspective, thinking about most of our patients are on possibly Medicare, some are in the VA and lucky to have some access to whole health. What would you say, would be the number one thing that patients can do or their carers can do to advocate for a shift in, this direction?
Yeah, I would say the number one thing is to ask for it. And you might even demand it if it's evidence-based, okay? You need to become your own advocate. When you go and get health care, it's important to have an advocate with you because as the patient, it's not always easy to know how to navigate the healthcare system. Bring an advocate with you. You should be an advocate for this also. Increasingly, when patients demand it, you see these things getting covered. As you move to value-based care, it's global payment. These things can be incorporated into that, and you don't have to worry actually about, is that part paid for, is this part paid for? So advocate for global payment. Certain types, Medicare is going in that direction. Medicare Plus actually can be properly utilized by healthcare teams very often to incorporate these types of things, but they have to know how to do it. And we provide a guide on that. So ask your healthcare practitioner if you're on Medicare, for example, and especially if they're using Medicare Plus, to actually take a look at the website, look at the billing approaches that I've shown how to incorporate these things for billing, and ask them to do an integrative healthcare, and they can get billed for it. For example, they can actually make money off of group visits. They can make money with health coaches if they know that their business office is set up to properly do that with insurance. It's not always easy. They have to work at it. We're trying to fit a square peg into a round hole, right? The fee for service into whole person care, but it's moving in that direction. I think the number one thing is to become advocates. Require it, ask for it in your insurance process if you can do that. And if you're getting Medicare, for example, and you have Medicare Plus, then go to your health provider and say, I would like you to do this. You can do it. Take a look at some of these billing approaches to get it covered and paid for.
That's great. That's really helpful. So this book has really been a game changer for me. And I think if more doctors could read it, I think it would be really helpful as well. Because I think it's really sort of a framework of a shift in thinking. And I think we really have had a number of guests on this program who eventually kind of end up saying, you know, it's really your attitude, your empowerment as patients, you know, these sorts of lifestyle approaches, the mind-body approaches. We've sort of really highlighted a number of those things in the series, even the most traditional of some of our leaders in the field in Parkinson's are really opening their minds to some of these things, I think. So I really appreciate all the work that you've done over the years to make this, you know, sort of a known and, you know, sort of recognized and a special board certification and having attention to this important sort of approach to medicine. So, and thank you for taking the time also to join our patients and our group today, Dr. Jonas. I really appreciate it.
My pleasure. Somebody just chatted and asked what the name of the book was. It's called How Healing Works. How Healing Works. So,
yeah, sorry, I think
thank
it's
you.
upside down or something. You can't read it from the, that's right.
Oh,
But it's very readable,
yeah.
beautiful anecdotes and stories, and just sort of following your entire, you know, journey through all these years of practicing and being in the military, and just really rich. You know, such an inspiration you've been, and I just hope that we can, you know, take some of your pearls and incorporate them and help our patients. And we'll definitely look through the resources that you have on your website. And our hope, just before we were talking with Dr. Jonas, was to maybe create some special set of these resources that may be applicable today for Parkinson's patients, so that we don't have to reinvent the wheel. So I appreciate your work, and thank you.
Love to do that. It was my pleasure. Thank you for having me.
Andrea, back to you for our goodbye wave to socially connect us a little bit.
Yes, Dr. Jonas, we always end everyone who has had their camera off. I invite you to turn it on. And this is our little dose of eye contact smiles from across the world. I saw Vera, hi from Australia. So thank you everyone for joining us. Thank you, Dr. Jonas. Thank you, Dr. Subramanian. Bye now, everyone. So good to see you. I'm going to scroll through and see all your great faces. Bye, David. Bye, John. Bye, Myra. Bye, Marjorie. Thanks so much, everyone. Bye.
Take care. Thank you.
Thank you. Bye-bye, everybody.
Bye.